So hello and welcome everyone. My name is Zami Tanashe Hemingway, and I am the SIBA Gender Affirming Project Manager with Denver Prevention Training Center. Before we start, if you all don't mind, if you could please change your name to the first and last name that you registered under so that we can take attendance. So, first and last name that you registered under, please. Also, we would love if you can add your pronouns in your name as well. Thank you, thank you, thank you. So, welcome to our second community of practice for January. Just in case folks are wondering, CEBA is short for Capacity Building Assistance. So, I am the Capacity Building Assistance Gender Affirming Project Manager. As part of this initiative, we are providing technical assistance in the West region to CDC directly funded community based organizations, or CBOs, and their partners to address social detriments of health, gender affirming and integrated services, and delivery of status neutral services for transgender and gender expansive people. We work closely with six prioritized states in the West region to collaboratively provide services for transgender people in alignment with the Ending the HIV Epidemic Initiative. Those states include Arizona, California, Colorado, Nevada, Oregon, and Washington. Thank you again for being here today. Now, I know you all signed up for This is the House That Love Built, which was on ballroom culture, the transgender community, and HIV care and prevention. However, we had to postpone the COP for February 15th. But don't fear, we still have a dynamic session for you all today, facilitated by Andrew Miller, who'll be focusing on gender affirming forms and electronic health records. So I will turn it over to Andrew to kick us off.
Hey, everybody. My name is Andrew Miller. My pronouns are he, him, his, and I am so excited to be here with you today to talk about affirming forms and EHRs. Let's be real. We recognize that's a bit less exciting than ballroom culture. So I appreciate your patience with this pivot we do. And I feel so lucky that the PTC group trusted me to ask me to step in for this last minute switch. So I'm going to do the technical difficult part of this and share my screen, and then we will get started. All right, can I get a thumbs up if you can see my screen? Wonderful, great. Okay, so we will dive in. So again, my name is Andrew. My pronouns are he, him, his, and L. I am Denver Health's LGBTQ Workforce Development Specialist. I work for Denver Health's LGBTQ Health Services Department. And in my role, I provide training, technical assistant, consultation, and coaching for Denver Health staff on LGBTQ affirming care and gender affirming care, as well as train nationally on gender affirming care and building gender affirming systems. So today we're going to talk a little bit about forms and EHRs. To do this, we're going to try to identify at least three aspects of affirming forms. We're going to describe where and how to collect affirming identity information within healthcare settings. And we're going to identify how electronic health records and forms can assist in affirming practices. But before we get started and kind of dive into the content, I want to hear a little bit from you around your feelings and your thoughts on forms and EHRs. So feel free to come off mute or type into the chat box. So the question is, what type of information do you think should be collected via forms and EHRs, electronic health records, in order to provide affirming care and services? Again, please feel free to type that into the chat box or come off mute and tell us what information you think should be collected. Oh, Zami, I will say with the way my screen is showing, I can't see the chat box. So would you be able to read those out for me?
Absolutely.
Perfect.
So currently we have pronouns and preferred names, more pronouns, assigned sex at birth, current identity pronouns, SOGI demographic information. So for folks who don't know, sexual orientation, gender identity, demographic information. current gender identity and current pronouns.
Neve, I love the use of current because we recognize identity is fluid and evolves and shifts at time.
Geographic location, pronouns, names, gender identity, race, ethnicity, soji. And someone asks, do we need marital status?
That's a great question.
Options for multiple preferred pronoun selections. And then names on insurance card for billing reasons so patient isn't stuck with a bill if it didn't match up. Personal information. And then same if the gender marker on billing information does not match. And then also think these forms should find a way to make this information prominent in a banner so that providers don't have to dig for the information they need to engage meaningfully with their client or patient. Someone put they dislike the other when discussing gender, and then mental and physical health history.
One of my favorite reasons to ask this question before we kind of dive into content is one, it lets me know what is important to you, and what makes me happy seeing all of this is these are the exact points that we're going to touch throughout this short presentation. Oh, and I did get my chat to work, Sami. I figured it out. Another person just said maybe an open option for gender rather than multiple choice. Yep, absolutely. So what we're going to do today is kind of review what is the pieces of information we need to get, and how do we get them? Because just because I ask a question doesn't mean I'm asking it in an affirming way or having those options that are affirming to someone's identity. I see another person just wrote it and said goals the client has for their healthcare. Absolutely. So the next question we have that I want us to review is, what impact do you think collecting identity information has on patient care? And again, please feel free to come off mute and share, or you can type it into the chat box. Again, that question is, what impact do you think collecting identity information has on patient care?
I'll come unmuted. I feel like whenever I'm signing up for medical care as a patient, when that information is collected, I already feel more at ease, and like the provider is going to know more information and be a safer person to talk to. And from a clinical standpoint, it gives me more information to make sure that I'm providing care in a way that is meeting the patient's needs where they're at.
Absolutely. Thank you for coming off mute and sharing, being able to understand the patient's identities and how that plays into the care. What else, folks?
I would also say that it prevents medical malpractice. I think that when it comes to the medical field, like we're still so used to operating in the binary, which is inherently transphobic, right? So I think what happens is when you don't have that adequate care, you don't have comprehensive care, you get a lot of people who fall through the cracks, and therefore, medical malpractice is being implemented.
Oh, absolutely. I couldn't agree more. We know healthcare systems are inherently racist and inherently transphobic and inherently homophobic and sexist and ableist. And so recognizing the misses that can happen when this identity information isn't collected, the harm this can do to our communities, and the malpractice that comes from that is so important for us to acknowledge and make sure we take action to change our system against. Zami, I won't lie, my chat box just went away again. So if you could read those that came in.
Yes, I got you. Okay. So we have Ben who said, huge impact. I know that if I had a patient in the past that was transgender, I would want to talk to my provider due to no easy way to communicate this. Someone else put, Jericho put, promotes a space of awareness and understanding. London put, makes me feel validated and comfort. We have Nevaeh put, competent and comprehensive medical care. Brianna put, feel seen. Brenda Del Rio put, transgender community is working to to match gender with personal information in legal papers. Can help provider best meet patient healthcare needs? Then comfort. Lots of folks are saying that it helps them feel validated, affirmed, and comforted, and seen in the scene. See if I missed anything. And then inclusion of broad identity information has potential for varying impact without solid and ongoing training for the administrators, deliverers of these forms. And then establishing a network of affirming healthcare agencies and their doctors.
Absolutely. I think these are all such great points, from having someone feel validated and seen to holding systems accountable. And Leslie, I couldn't agree more, making sure that we're not just throwing out a form, but actually providing training to staff that is necessary to collect information in an affirming way. And then I see we had another one come in. In a public health sense, it provides health data to our orgs and health departments on health trends in our communities. We recognize trans and non-binary communities are barely ever included in data collection or health research. And so if we don't collect the information, we can't understand the trends and needs of communities. So from a data collection perspective, making sure we have the language necessary to be affirming while also gathering that information is absolutely necessary and needed. And then, yeah, Zami, I see you put in, which also leads to increased funding, which we know is necessary. And with the group of folks we're talking about right now, making sure we have that information, collecting it for the patient, for the staff, but also for the requirements of our grants is really needed. Thank you all so much for participating in this and for sharing with me your thoughts, knowledge, and ideas. What we're going to do now is spend about 15 to 20 minutes kind of just reviewing some base level content around affirming forms and EHRs. So for some of you, this might be very common knowledge and things that you're already enacting within your system. And for some folks, this might be brand new. What I ask is, as we're moving through this, please use the chat box or come off mute at any point to ask a question, to make a comment, to share an experience of how your system is navigating this, so we can all learn together when navigating how this one part of systems change can really make a ripple effect. So just to do a base level review, what information should be collected on forms in EHR? And I say should within quotations because this is going to be different for every single organization that we work in. The services that you provide is somewhat necessary to know what information is needed to be collected. Sometimes this is based off of your services. Sometimes this is based off of the information you need for grants that you're on. So it's important we understand the why we're collecting the information, not just to ask the question to be affirming. And there's certain information we do need to be asking at every single form to be affirming. So first things are name and legal name. So the name is the name someone goes by. In some spaces, it's called preferred name. I prefer the term affirming name, a name that affirms someone's identity, the name someone uses, or we can just say name and legal name to differentiate those two. If your system doesn't need to collect legal name, then you don't need to collect legal name, then we don't ask it. I work for Denver Health, so as a medical organization, we have to collect someone's legal name. And so to do that, we need to make sure that we're first getting the name someone goes by and then collecting legal name. We should have pronouns on every single intake form that we are collecting. Any form that we are asking folks to put their name on, we should also put pronouns. We need to know how to address people and refer to people, as well as document for certain requirements. And then this next chunk we refer to as SOGI identity. So SOGI is used within healthcare systems. And in this, we're talking about sexual orientation, gender identity, sex assigned at birth, and often pronouns are included within this. Again, check your why. Is it necessary for you to collect sex assigned at birth based off of the services you're providing? Maybe not. But maybe it is required for grant purposes. If you're a medical organization, then you are probably having to collect sex assigned at birth. Also, we always should be collecting gender identity because, again, this is how we affirm and respect someone's identity and recognize some of the unique considerations that we might hold around that. Next, if you're an organization that has to collect things like legal name, or you work with health insurance, you probably have to collect legal gender marker as well. This is the marker that goes on someone's legal ID, passport, and sometimes it aligns with birth certificate, and sometimes it doesn't. Same with sexual orientation, information that we know to be able to affirm someone's identity. And we recognize there's a lot more data than just sexual orientation data that needs to be collected. Race, ethnicity, written and spoken language, disability status, veteran status, and many, many more things dependent on your organization and the services you're providing. And I wanted just to break down SOGI information a little bit further. I think best practice is having a write-in option, that we don't make choices that people have to choose from, that we do write-ins, because everyone's identity language that they use to define themselves is personal and unique. And, you know, I work for a very large hospital system where write-in is not an option for every form we're doing. And so if you do have to put different options, we want to make sure that there's a breadth of options given and that there is always a write-in option that is given. And as mentioned earlier, let's move away from using that term other to putting option not listed or just write-in, and always having a way for someone to type in that information and the word they use to identify themselves with. So you can see for pronouns, we have a large breadth of pronouns we can pick from. Things we know about pronouns, gender identity, sexual orientation. There are over 100 different terms that we can use for these identities. And there's more and more and more language being created all the time. And I think we're really lucky to live in a space where folks are creating language and speaking language into existence that helps hold themselves at home, that helps find language that feels true to who they are. And so we need to recognize that our forms will always have to be evolving and shifting and changing. So you can see for pronouns, obviously we want to have a breadth of pronouns. I also think that it's always important that we have the option for people to pick multiple identities and multiple pronouns that can be listed. Some people might use she and they, some people might use Z and their name. And again, we want to make sure that folks have the ability to choose all of the terms that actually feel true to them and the terms they use to communicate with us. Around gender identity, again, you'll see that we have a breadth of options around this. We want to make sure that we're using terms like cisgender and transgender, as well as expansive identities like non-binary, like agender, like two-spirit, and again, that write-in option. Because again, we recognize that gender identity is so vast and broad, and especially within the language we have within the United States is incredibly limiting. And we have really colonized the term transgender and gender identity as a whole. And so again, we can't create a form that is going to have every option needed. So that write-in is really necessary. Next, for sex assigned at birth, the general language we're using in healthcare facilities for sex assigned at birth is female, male, intersex, and then again, a write-in option. Some people might not know their sex assigned at birth. Some people might have been assigned a sex at birth that isn't actually aligned with the identity of what they know to be true. Some people who are intersex are assigned intersex not just at birth, but throughout their lifetime. And so folks might want to be able to put down more than one option. And again, that write-in is necessary and needed. Legal gender marker. Boy, oh boy, I won't lie, we're going to town with this at my hospital system right now to get the X included. We recognize within the United States, there are multiple states that have options that are female, male, and X listed. X can now be listed on state IDs as well as passports. It is incredibly important that we get our EHRs up to date to include this information. And I won't lie, that's a push that is taking some time within certain healthcare orgs to be able to include that X. And then sexual orientation, again, we want to have a span of identities and always have that write-in option. Last thing to note about any identity information, again, identity is fluid and ever evolving and changing, and folks should be able to have the opportunity to fill this in whenever they want, as well as to be able to change this whenever they want. And I see that we had some chats come in. Zami, do you want to read those out for me?
Yes. So it says sometime transgender, and I might, if you feel comfortable or you have the ability to unmute, Brenda, would you mind saying your statement? Because I may mess it up a little bit. If you don't have the ability to do that, then I'll do my best. Let's see.
Yes, basically sometimes with my clients on a personal situation, and an assistant for my appointment in my clinic, sometimes for the personal, the medical service to prevention and HIV or in my situation with living HIV. Sometimes I listen, sometimes to, in the past, it's a calling for the real name. It's a very sensitive with myself, because I'm saying, oh my God, why you say me or why you call me Francisco? My name is in the paper, Brenda, or send me my name, please. Send me the second something of Del Rio, Gonzalez, Ortega, something like that. Sometimes as I continue to listen for my clients, it's the same situation. I don't know, maybe it's a pretending or maybe opportunity for more trainings and sensitive this situation for the umbrella transgender and something like that, and implement for more in the all about in the United States because it's necessary to change like this situation.
Yes,
Thank you
absolutely.
so much.
Oh, thank you, Brenda. I couldn't agree more. I mean, we recognize that misnaming that happens in these systems is harmful and dangerous and degrading and dehumanizing. And the fact is, I'm a big believer as a trainer, you can't create a form if we're not training the staff. And the staff needs to be trained on where to find this information, how to use the information, as well as what to do if they mess up. That apology is so important. And to understand the impact that what they think is a small mistake has on our communities.
Thank you so much. And then we have Ty, who just put speaking language into existence. And so speaking to that right in, letting us know how we would like to be referred to, etc. So thank you, Ty. And Carla said that they already use this option in California.
Oh, I love that. That makes me so happy. It always feels exciting when you know that your system has this language and is using it, because it's a small but really key part to building that affirming system. So just a little, what I like to call like geek language around identity development, one of the whys. We all have a why we should collect this information. The why is that this is the affirming and respectful thing to do, that this is patient-centered care. And we also work in healthcare systems where sometimes we have to navigate a different why to sell it to different parties in our org. When I do EHR trainings for executive staff and IT teams, this is some of the stuff that I put up to remind folks that there is push coming from Joint Commission, from National Academy of Medicine, that collecting SOGI information helps center our patients and provide patient-centered quality care. We hear from HRSA saying that this is a highly recommended information to collect to promote culturally sensitive, which is a term I hate, but culturally sensitive care delivery and to reduce health disparities. And then lastly, something that I think folks don't often know is that it is now a requirement that EHRs are able to record SOGI data as of 2018. Most EHRs, though, haven't actually done the update that is necessary to do that. But we as healthcare organizations do have the ability to kind of pull these things to say, nope, under this requirement, so the meaningful stage, this is a necessity for you to do. It is then on the organization, obviously, to do the training for staff, but EHRs are required to be able to house this information. All right, so now we're going to do a quick poll. So SOGI information was essentially trialed by the Fenway Institute in Boston, and they worked with HRSA to essentially do a nationwide study on collecting SOGI information. So the question is, from this nationwide study, what percentage of patients reported not being distressed while being asked sexual orientation and gender identity questions? So what percentage of patients reported not being distressed when being asked these questions?
All right, Andrew, it looks like we are at 55% and rising. If for some reason the poll isn't working for you, feel free to put your answer in the chat as well.
Thank you so much, Misty.
Welcome. All right, we are hitting 70%. Awesome, Andrew. I am going to end the poll now.
Perfect, thank you. So we see that from our group, we think 27% of patients reported not being distressed when being asked sexual orientation and gender identity questions in this national survey. And it's actually 97%. 97% of patients reported not being distressed when being asked sexual orientation and gender identity questions. Additionally, we have 96% of patients understood the questions and could answer them with ease. And additionally, the overwhelming majority, 4 out of 5 patients, understood why these questions were being asked and why it was important for their health. I think oftentimes in healthcare settings, we assume the patients are uncomfortable, but in the reality, we project our own discomfort onto these patients. This statistic helps to represent that fact that oftentimes we build up the potential distress someone might face when being asked these questions. But in reality, these are necessary healthcare questions. And we ask personal information and data collection information on all of our patients in healthcare settings. And these are questions that we can help normalize by asking. So next, what I want to do is just do a few more parts just on some of this like real details of asking this information. The fact is every organization is different, and where we collect identity information is going to be different and unique to each of you. What I want to do is just briefly run through a few different spots you could collect this information. First, patients could put this information in at home. So if you have virtual forms or intake forms that folks can fill out online, that can be included in those forms and people can fill them out from their own house if they have access to that kind of technology. That means that information would have already been collected when that patient has arrived and hopefully already input into the EHR. Next, folks can register when they are in your clinic. So that could be an electronic form that they are using in the waiting room or a paper form that they are filling out in that waiting room. But they are filling that information out themselves in your space and then turning that in before being taken back with a staff member to work. That then generally means that clerical staff are entering this information into the EHR and creating that patient file, or that's done if it's electronic. Then the last two places that can be done is actually by a staff or provider one-on-one with that patient. Here at Denver Health, we actually have our MAs ask that when doing a health history after the patient has been roomed. So they run through general health questions, and when they're collecting demographic information, they're asking that to patients one-on-one. Another option is having the provider, so whether that is a therapist, a social worker, a medical provider, an NP, asking those questions directly to the patient, again, one-on-one. The one thing that I do want to note is if we are verbally asking and collecting this information with patients, we are doing that in a confidential space. We are not asking information about this in spaces like waiting rooms or in group settings. This should be done in a one-on-one setting. And then the last thing I will say, no matter where you are asking this, so from your online forms to a provider asking this, there needs to be something said about confidentiality. Where is this information going to be housed and who has access to this information once that patient puts that into the system or shares that with a provider? All right, so I have 3 more slides just for us to go over before we kind of lean into some discussion. So obviously I work for Denver Health, so I had to pick Denver Health's form. We have all of our forms on our website. So our hope is that our patients can go to the website and fill this out in their own time. We also have a full-time patient navigator. So our navigator would receive this form and then type it into our EHR to create that file. We used to have options that folks had to pick from, but what we recognized is it is far more empowering and inclusive to have the ability for folks to be able to type in or write in. Obviously, some of this information is required for us to collect as a healthcare system, and the other information we recognize just helps promote good affirming care. And I, will also share that forms, EHRs, healthcare systems in general, it's a constant QI process. We have redone our form 4 or 5 times. We will probably have to redo it 4 or 5 more times based off of community feedback and what we recognize is the shifting space of affirming care. All right, and then what does this look like in EHRs? So here at Denver Health, we use Epic, which is a very large EHR. I also have a lot of experience working with things like Athena. So for our SOGI data collection form, we created a separate form that then pops up when patient files are being created. We actually train our staff to read these questions exactly as they're written. We found that having some base level scripting was helpful for staff. So generally, we train them to say beforehand something like, excuse me, up next, we're going to ask you a few questions. These are questions we ask to all of our patients here at Denver Health. If you don't want to respond, that's absolutely fine. And then these are the boxes that we have listed. In an EHR, we couldn't have just a write-in for every single one. We had to have some categories around this. So you'll note that we have main categories, but then we have 3 other boxes. So not listed. And if someone presses not listed on this smart form, a box appears and you can do a type in option. The next is don't know. And then the third is choose not to disclose. And again, we have these for all of these questions. And then for things like sexual orientation, gender identity, sex assigned at birth, and pronouns, actually for all of these, folks can pick multiple boxes. So again, we recognize language is limiting. Language can be inclusive and helpful, but it also limits us to one space. And so we want to make sure that folks can use multiple words to identify with. So we found it to be really important that folks can pick multiple boxes, as well as having a write-in option, even within an EHR. And then just to show you, this is then how that's translated into an EHR chart. Again, this is that big electronic health record that we work from. So this is what communicates for all staff at Denver Health. For Denver Health, and this is a fake patient file that we've created, we're able to collect the patient's affirming name or name they go by. And then we have their legal name collected below in smaller levels. As Brenda brought up before, even collecting both pieces of information can make it feel really, one, scary that you're going to be misnamed because you still know a legal name. And if that information is not housed correctly, staff are more likely to misname someone. So we wanted it to make sure that the name we're calling someone is in bigger letters, and then someone's legal name, which has to be listed in our EHR, is in smaller letters listed below. We then have patients' pronouns are listed in the chart, and that is pulled from that form that we showed on the last slide. And y'all, it's not perfect. We are still in a QI process around this. So we're pushing for a few new things. One, right now, this male sign is representing gender identity, but it's not using gender identity language. So we're working for that to be switched over to gender identity language instead of sex assigned at birth language. So right now, staff can hover over that male sign, and we call it a hover to discover, and it will pull up all of that SOGI form on there. Another thing that we're trying to get rid of is the term sensitive listed after identity terms. This information isn't sensitive, it's confidential. And so if there's information on a file that's confidential, it should be listed that way, not sensitive. Again, we don't want to flag trans and non-binary people's charts because of identity. We want to make sure that we have the ability to collect information to help promote safe, respectful, and affirming health outcomes. And then considerations. So, as I've said 4 times now, you can't just collect information if you don't train your staff on how to do it correctly. So at Denver Health, our SOGI training, that form, that EHR and documentation is built into every LGBTQ training we do. So we review what it looks like, how it's collected, and then we have staff role play it. I think role play is a really big part of how we can train staff to have better patient interactions. For some folks, asking someone's sexual orientation is a completely taboo concept, or is against some of the cultural beliefs and ideas that they hold. And so we have to recognize that even though that this is necessary information for us to collect, this also can rub up against some of the values and ideas and beliefs that folks hold. And it's important that we provide those opportunities for conversation, for training, and for practice before we put this in place, so our patients aren't the one who turns into the educator in this. Other things, workarounds. Y'all, most EHRs are not as fluid as things like Epic are. And so it's important, if you're going to really try to collect this information, that you work with your team and figure out what are your workarounds. An example of a workaround, right now at Denver Health, when you print out those labels, the patient labels that have to go on paper charts, it has a patient's legal name listed first and then their affirming name listed in parentheses. Obviously, this means that patients are more likely to be misnamed. So our amazing clerical staff have really put their heads together to figure out some workarounds. So highlighting a patient's affirming name on every single label that goes through and how they communicate that. Even if that means taking that extra second and having that conversation with a provider or the next staff member who's going to interact with that patient. We have to make sure that this is communicated around and that you can advocate within your EHRs. So really making sure that you're asking for what information has to be collected and then creating very clear standard work of how this information is collected and how it's translated into an EHR. And then the last consideration I want to share before we just have conversation is confidentiality. So identity information is personal information. Specifically, when I'm talking about working with youth, I think it's important we check how confidentiality is used and how we communicate that with patients. So right now at Denver Health, we ask those SOGI questions to all patients over 13, but obviously that means that parents, guardians, and family members could have access to those files. And so sometimes that means we're not actually collecting that information. We're having very clear conversations with youth, what families can see and what families can't see, because we never want to put our clients or patients in a situation where we're outing them and creating an uncomfortable or unsafe situation. I'll share just the scripting I give with staff around this. If I'm working with a youth, I wait until I'm one-on-one so that parent or guardian is out of the room. I go back in and do my introduction. My name's Andrew. I use he, him, his pronouns. This is what I'm doing at Denver Health. What's your name and pronouns? Patient tells me their name and pronouns. Great. It's so nice to meet you again. Can you let me know what name and pronouns would you like me to use when your parent is back in that room? And then that youth or that person gets to make that choice. Well, I go by Nate and he, but when my mom's in the room, can you call me Nancy and she? Absolutely, Nate. Thank you for letting me know that. So just to clarify, when we're together, I'll use Nate and he, but when mom's in the room, you want to use Nancy and she. Great. Thanks for letting me know. I want to talk a little bit about our computer system. So we're able to collect things like the name you go by, as well as your legal name or birth name, as well as maybe some different identities you hold, gender identity, sexual orientation, pronouns. But the thing is, because you are XYZ years old, your parent would have access to that information. Would you like this in our computer system or would you not? I'm not going to make that decision for a youth. We're going to lay out those options and let them know what that is. And then we follow their lead on that. It is really important that we communicate what is confidential information and not confidential information, not just to our patients, but to our staff, because our staff are the ones who are explaining that over and over and over again. And so we have to make sure that when we roll out these things like affirming forms, like EHRs, we've identified where are the gaps. Where do we need to grow? Maybe that's some staff education, maybe that's some written material. And what are some of those areas we could get into trouble? Confidentiality is a really big one. Billing practices are another big one. What name is going on a bill that is being sent out? What name is going on a pharmacy label that's being given to a patient? And then if legal name has to appear in somewhere, I'm letting my patient know, hey, when you go pick up your medication, your legal name is going to appear on that medication. That is kind of the way our system works right now, and that's something we're advocating for. But I just wanted to let you know ahead of time. Again, we want to have those discussions with our patients ahead of time so they are not the ones who are constantly having to come to us and advocate for their dignity, for their right, for their humanness in navigating a system that can oftentimes be harmful. All right, y'all, that was the base of our content. And I know we zoomed through that quite quickly. But also I assume for a lot of you, this is not new information. This is a little bit of a refresher. So what I want us to do just for the last few, like 20 minutes, is run through some of these questions. So again, same format as before, please feel free to come off mute if you would. And if you have to type, that's also fine. But let's do these in orders. So first, right now in your organization in current state, what identity information are you collecting?
I want to start with collecting the name and date of birth, and also what is the identity, like a transgender, or what is the sexual orientation?
Yeah.
I'm from Bienestar. My name is Carla Talia Flores.
Hi, Carla. So nice to meet you. So you're saying you
Nice to
collect
meet
things like
you.
name, date of birth, sounds like sexual orientation, gender identity.
And how they identify transgender women and non-conforming, all that.
Yeah, and so how someone identifies for that
Yeah.
gender part.
And sometimes we ask the client, how you want me to call you? Because sometimes they have a men's name, but we don't call it with that name, under that name. We can put a real name and we can put AKA and put a woman's name.
Yeah, that's a great point. So making sure we're offering those two different spaces.
Yeah, because we don't wanna make the client feeling so badly to calling another names that is not a name that she prefer or her prefer.
Yeah, absolutely. Making sure that we're going with that name that someone goes by.
Yes.
And I think that's another great point, Carla, of also making sure we're doing some offering of who gets to call you that name. For myself as a trans person, there are sometimes that there's a pronoun that I'm comfortable using in public that might be different than the pronoun that I'm comfortable using with my provider. So we want to make sure that folks have options of what names, what identities they share with certain people and maybe not with other people involved in that team or organization.
I know my other job is working on the Trans Wellness Center for the LGBT Center. And we have to ask the client, how you want me to call you?
Yeah.
What is your preference before we start our conversations? Because we don't want to make feeling uncomfortable the client, because it's part of our job, asking the client first.
Absolutely. Making sure we're giving clients those options and getting that information before we even start.
Yeah.
Absolutely. Thank you, Carla. For other folks, what information are you collecting in your organizations?
I'll share a little bit in the chat, Andrew. So Ms. Stry put, we work in an EHR and also have a separate database for our clinic that is HIPAA compliant but does not link to the EHR. Demographic data is collected once generally and includes SOGI data, but is inconsistently in the EHR. Recently, the medical assistants have started providing an additional paper form to collect data, but it is inconsistently used and often not updated in the system once it is collected. So information is collected and updated generally just by the staff that have prioritized and recognized the importance of talking about and collecting this information. And then Richard put, my previous org recently implemented Epic, so now they collect all identity information.
These are such great points. And I really appreciate that first one of, you're right, we can pull out forms, but if we're not training staff on not just how to do it, but why this is so essential to the care that we're providing, it's going to remain incredibly inconsistent. I won't lie, we rolled out our EHR, our SOGI form 4 years ago, and I've been training with us 3 years. And even having a full-time trainer on this, we're still hitting spaces where it's inconsistent and really trying to identify what is it that's coming up that's making this information, or what's the barrier of why this isn't happening consistently? What kind of work can we put in place to make this more routine within someone's experience in a center? Does anyone have any other information that they want to share that they're collecting at their organization?
So some things just came through the chat, Andrew. So Christina said, La Vida Project is a part of FYI Plus innovations. We have a lot of work to do in our information gathering process. To be honest, we are slowly educating our internal providers with safe zone trainings. And then Ben said, I do orientations for 2 of the 5 or 6 programs in La Vida Project. Have some questions that seem vague and not affirming, like GIFF, which is a juvenile justice EMR. However, the question is very odd. It has cultural identity and gender identity as a question together. It puts the participant in an odd space.
I refuse to ask the question because it's not genuine, and it's like in a whole nother section away from their name, their gender identity, and it's just like, okay, I feel like I already talked about that because I was like, hey, what were you born as? And then do you identify as that still? And just like leave it open. And then I feel like I'm like, I don't know how to address this question and be like, what is cultural identity issue? Or like, am I talking about people like Eminem that think, I don't know. Yeah, so it's weird.
And I'm really glad you brought that up because again, and this is that thing where we think forms and EHRs are just like simple stuff, but there's a flow that has to be there to make it affirming. Otherwise, it can feel really othering to patients and clients. And so I agree, if we're not asking these questions with the rest of the identity information, what is the vibe that we're giving across there? What is the purpose of that question and how that's coming across, especially for folks where being asked this question doesn't necessarily feel easy for trans and non-binary folks. For myself as a trans person, when I've been asked this in an intake with a provider, my gut comes out. Am I safe once you know this information? Is my treatment going to be different once you know this information about me? I know it's necessary to care, but has rapport been built, and is there a sense of why this is being asked? When I do these trainings for Denver Health staff, I train again on that intro section of like, I'm not going to ask a question if I'm not going to explain why we're asking it and how the information is going to be used, because we want to set folks up for success. Thank you so much for sharing that. I see we had another question come in the chat box from Leslie. Does anyone have experience with putting this broader gender identity info on an EEO1 or other EEO forms?
I'm so sorry to be a pest. In my system, that is the major sticking point to expanding how we whether and how we gather broader gender identity information, as well as other important aspects of demographics to provide good care.
Could you share with us a little bit more of what is EEO?
Oh gosh, thank you. So it's thank you, Sami. The equal employment opportunity. There are a variety, and I am so at the edge of my expertise here. So if there are any HR folks on the call, shut me up and you can drive. But I gather that there are a variety of formal compliance, equal employment opportunity forms that are required for organizations to complete. And those forms really get pretty circumscribed they ask you about male and female, and they really drive you to put all of your employees into those two boxes. And at least in our system, there is a belief around the form doesn't allow you to collect other information, broader information about people, and therefore we can't collect, therefore it doesn't serve us to collect broader gender identity information. So anyway, again, I just would invite anybody who knows more than me to chime in.
Oh, Leslie, I think that is so important because again, we recognize affirming systems aren't just patient care. This is also who we have at the table, who our staff are, and their ability to fill out their identities and safety in our HR forms.
Yeah, and I suppose here, I thank you, Andrew, for that, Claire. I suppose here I'm talking about employees rather than those receiving our care. So sorry, I took a little bit of a turn.
Oh, no, that is so important. This is a key component of affirming care. It's not just patients, it's also staff.
In the chat, Miss Jai did say that she worked for an organization that used to collect gender identity and sexual orientation identity as a separate supplemental form for employees. So that is an option. We also provide technical assistance, so we can follow up at the end of the call as well.
Sami, thank you so much. I appreciate it. I'll stop being a pest now. Thank you.
Not a pest at all. This is key information. This is the reason we like having these conversations. I'll share at Denver Health, that is also what we do. There's the general form that you fill out for EO, but then there's also the rest of the demographic information that's collected in the general employment form. And I believe that's currently how Denver Health is kind of providing those additional questions that use affirming language.
Next off mute, this is London. Hello, can you hear me?
Yes.
Hi, so my question, it's actually not a question, but it's a comment, and it's not about particularly a form, but it's an actual question about a question that happens, and this typically happens in emergency room settings, not at the not during my regular clinical visits. But the question is, when was your last period? And that question in itself, I mean, if you're a trans man who goes in to the emergency room and say, your identifiers say male, it may not recognize your body, right? And that opens up the door for misdiagnosis in itself and malpractice there. But it also can cause a lot of dysphoria when the question is asked, right? And even if myself, when they ask you when was your last period, and though my forms say female, that for me is a dysphoric question. How are emergency rooms or other spaces, what are ways that potentially that can be worked out either with forms or just rearranging the question or adding to the question?
That's a great point. What do folks think? For some of this information that we recognize as gendered medical care, like when was your last menstrual cycle, how is a way we can ask that in an affirming way, and how do forms and EHRs play into that?
I know that at Planned Parenthood of the Rocky Mountains, when I was working there, that they had the option to click another button where it would say, you have the, of course, menstrual date, and then you have the non-applicable, which kind of avoided that, which was nice for some of my non-binary folks to just click that button and just kind of keep going through the questions without having to stop and be like, well, why isn't that there? Or to put them on the spot. It was just like, oh, no, they don't have that. And then either it was like they had a hysterectomy, they're trans, and like that's when the doctor would go in, right? And they would go and have that confidential, intimate conversation, and then it felt safer.
That's great, Ben. Thank you. What else do folks think about that?
Hey, Andrew, this is Bev.
Hey, Bev.
I was just going to say that's a very interesting thought for us to consider across care systems. I think the more we learn how to create this expansive language, so do you have periods, or are you, because that would be true for an older adult female who is in menopause versus, it's all these nuances to would someone be having periods, period, right? So I think the more we figure out across care systems how we language in ways that's affirming for anyone we're talking to is gonna benefit, again, our LGBTQ communities, along with everyone else who we may be, misstating what's going on. So yeah, I think that there's a lot to be done there.
Absolutely.
I love that
Bev.
question.
Yeah, go for it, Leslie.
No, sorry about that. I love that question. Are you having periods? And the answer to that may be yes or no, depending on a whole host of factors, right?
And it goes along not just things like menstrual cycles, but also pregnancy tests that are required for a lot of medical services that can be provided in large hospital systems or medical systems in general. We work a lot with Denver Health staff, especially our emergency department and urgent cares, of what is the trauma-informed way to say this? And how are we offering outs for our patients that can pump the brakes and say, I cannot continue this conversation or answer that question at any given moment? I agree. I see Ty put in that this is a good question and potential another topic for COPs, and clearly you all can tell is a subject that I love to talk about, because there are certain questions for medical systems that we have to ask. It's all about how do we ask them in a way that is patient-centered and trauma-informed and will not further cause harm to that person's mental health, well-being, or physical health. And I saw that we had someone else write in to say, oops, I lost that. That a lot of national data has shown that many trans and non-binary folks have avoided emergency rooms due to that situation, like you've mentioned, and other forms of dysphoria and fear of being misgendered and experiencing violence. We know that over 25% of trans and non-binary folks have been harassed or disrespected in healthcare systems, and 2% have been physically assaulted in healthcare systems. We know that 1 in 3 trans and non-binary folks will delay care even in dire circumstance because of the fear of harassment and disrespect. We recognize that healthcare systems are not safe for trans and non-binary folks to be in, specifically Black trans women to have to navigate. And so again, we have to constantly be aware of the harm that our system has caused and has the potential to continue to cause as well. And then I see that Ari wrote in that the same question about pregnancy and birth control. Absolutely. They said that they find most forms ask and say for women only. Again, what are those ways that your forms or your systems are flagging that trans and non-binary people aren't real or don't exist or don't have health needs? Again, not only is it not affirming, but it can miss something that is really pertinent to medical care and medical needs as well.
Can I add something to
Yes, absolutely.
that? I just want to add that I would advocate also for what we really need to collect on a form versus what the conversation is in the exam room between the provider and the client or the patient. I mean, it's pretty rare that as far as data collection that we're going to have to report the number of people that we see who are able to get pregnant, right? And I know that in larger systems and in systems that are medical systems, say, versus CBOs or something like that, changing forms is really difficult sometimes because of all of the different departments and people and interests that are involved. But as far as being client-centered, the need to check a box on a form, I think, should always be questioned.
Yeah. I love that. I love that idea, that difference between not just, so what's collected on a form and all the issues that come with forms and changing them and shifting them versus what is that interaction between patient and provider, and what information are we collecting to really understand the health needs, the health stories and goals of that patient? And what is the language we're using to have that conversation? My hope is that sometimes those EHRs can help affirm and build some of our providers who are newer in that. And sometimes those don't align at all, especially when we're facing some of those limitations. Zami, I do see that it is 11:58. Do we want to read through the last few things in the chat, or do you want me to turn it over to you for that last slide?
I will read through the chat very quickly, and if you want to go ahead and go to the last slide, I'll just transition to that. But